then why are we labeling it nasal breathing and mouth breathing? That's only describing the way in which air enters the body. How do we actually breathe? We are diaphragmatic breathers. And if you look at the whole concept of respiration, there are 7 components to it, in my opinion. Diaphragmatic breathing, craniofacial anatomy, nasal patency, which is directly related to craniofacial anatomy, lip seal, tongue position, which is muscle function, posture, and a balanced autonomic nervous system. There are 7 components to breathing. And my fellow compatriot is only talking about 1. It's like telling somebody, you know, I'm limping because I've got 1 leg long, 1 leg short. You're doing it for 30, 40 years in your life. And one fine day, an orthopedic surgeon comes and says, I'll fix that discrepancy and you'll be walking normally tomorrow. Do you think that will ever happen? You need physiotherapy, you need muscle training, and you need to change the way the body has been programmed to do something wrongly for decades. So doing structural correction is only one aspect of what we need to be talking about. There's 6 other components, and there are definitely gender differences. We'll be talking about it more and more. Let's take a look at everybody in this room. Has anybody in this room had any orthodontic or orthodontic work done before? Can we see a show of hands? Very good. Now, how many of you do you think in this room needs orthodontic surgery? Quite a few, isn't it? How many of you all think you've got breathing problems? Oh, good, at least my preaching and talking about this seems to have entered some kids after 10 years. So do you realize now that it is a very complex area that we are actually dealing with? And it's more than just airway anatomy. It's neuromuscular control, it's ventilatory control instability, it's arousal thresholds, and there are also systemic factors. My dearest colleague also doesn't tell us the fact that when you put up a patient for orthodontic surgery, their selection criteria is very, very, very strict. You wouldn't be doing orthodontic surgery in somebody with a BMI of 32 or 33, would you? Would you? Because even if you correct that structure, do you not think that the weight is still going to be an issue? If the patient makes an effort to do something about it. So do you realize that it's like a cardiologist, you know? You go and see a cardiologist, they put in a stent, and then after that they will say, oh, we fixed your problem. But that's not the end of the story. That's the beginning of the journey that changes. And it's the same philosophy that we've got to have in airway work. We are only one step of the journey to make the patient realize that they've got a lifetime of changes that they need to work on to maintain good health. And we need to realize that breathing seems to be an important function that a lot of us take for granted. The moment you snore, it's obstructed breathing. And I tell my colleagues, every single problem in the human body today that we are dealing with comes from the basics that we are not doing correctly. Hypertension, cardiac issues, anything and everything, even diabetes for that matter. So just by correcting the structure without really understanding that there's a whole big ocean out there, the structural correction is only one drop in an ocean. But it is a vital drop, and I don't disagree with that. But like I said, a lot of it is actually much more challenging than what we actually thought it is. And there are true gender differences. It's very different in men, it's very different in women. It's not the same boat. A woman with an AHI of 15 is equivalent to a guy with an AHI of 45. So we are looking at 2 different ball games altogether. So we have to be very, very cautious when we are coming into this area. It is not a simple 1 + 1 = 2 equation. It's a very complex modality of treatment that we are looking at. And it's almost like cloud computing. You take the patient, you throw up the problems in a cloud, and then you see which one you're going to fix first. In some patients, even though with a very narrow skeletal box, we see this very often in women. Their autonomic nervous system is haywire, they're very sympathetic driven, they've got anxiety, they've got panic attacks, they've got depression. And the moment you touch the structure and you do anything without really rehabilitating or pre-rehabilitating them before doing the structural work, you may be actually doing more harm than good.
Dr. Jeevanan?
Yep. Time is up.
Almost.
All right.